Morning. Thank you so much for hosting. My name is Katie Merrill. I'm the Director of Rehabilitation Services at OMH Central Office. And as part of that role, I oversee core services statewide. I'm joined today by Amanda and Nicole, and I will let you both just introduce yourselves right up front, and then we'll get going with some slides.
Good morning. My name is Amanda Palmain. I am with the Office of Mental Health, and I am the core liaison across New York State.
Hi, Nicole Pickett from Fountain House, Director of Managed Care. I oversee quite a few programs at Fountain House, one of which is core services.
Thank you so much. All right, so we're here today to talk about core services and what core can offer for individuals who reside in supported housing. We're going to do a little bit of a core 101, tell you what these community-oriented recovery and empowerment services are all about, who can access them, and what that looks like in terms of making a referral. And then I'm really excited for you all to hear from Nicole about how core services has been implemented at Fountain House. We've worked closely with Nicole for years. We've gone out and seen her services, and they truly offer a wonderful program, and I'm really excited for you all to hear about that. So we'll go to the next slide. And the next slide. Okay, so just to get you started with a very brief overview, we're talking about community-oriented recovery and empowerment services. These are person-centered, recovery-oriented, mobile behavioral health supports. They're really focused on skill building and self-efficacy, so making sure that people have the skills and resources that they need, and also the belief in their ability to be successful in valued life roles. We want to promote and facilitate community participation and independence. So we do this through 4 services. First one is Community Psychiatric Support and Treatment, or CPST. I'm going to introduce a lot of acronyms today. The second is Family Support and Training, or FST. Then we have Psychosocial Rehabilitation, or PSR. And lastly, Empowerment Services Peer Support. I really don't use much of an acronym for that. I just call it peer support. These 4 services can stand alone or work together. So individuals have a choice in terms of whether they want to receive 1 service, 2 services, all 4 services. But the idea overall is that through any of these services, we're promoting that independence, supporting self-efficacy. All of them are delivered from the recovery orientation and have a very strong rehab bend to them, which you're going to hear about today. So it's not a comprehensive program model. You are not forced to accept all 4 services. It's really based on what the person wants. Next slide. So why core? Why are we talking to you about this today? Why should you even be interested? Very briefly, here's my sales pitch. Number 1, these services are community based, which means that they are provided where people live, work, learn, and socialize. So there typically isn't an expectation that someone would need to come into an office. There's a good amount of telehealth available based on the person's preferences, but very often staff are going out to people's homes. They are going out to libraries and parks and work sites or jobs, and supporting people with being independent in those settings. So that's really exciting, and it's unique. Core services focuses on helping people gain the skills that they need to be more independent. As I mentioned on the last slide, they are a la carte, meaning that the person can receive only the services that they need and prefer. So they get a lot of control and choice when they're selecting the services. And of course, they're always individualized, person-centered, recovery-focused. They are nearly always provided one-on-one. We do have some allowances for some groups, but really it comes down to that relationship between the individual and the practitioner to figure out what's going to work for this person. Okay, next. Now, I do want to mention the scope of services because there are a lot of misconceptions out there. So number 1, these are goal-driven services. They are focused on supporting people with improving their quality of life and their satisfaction in life roles. Now, I think I've said life roles 3 times in the last 5 minutes. So what is a life role for those of you who aren't living in the world of rehab every day like I am? It is any role that an adult takes on. It could be being an employee, a parent, an adult sibling, or an adult child of elderly parents. It could be a community member, a volunteer, a student. So think about all of the roles that you have in your life and how satisfied you are with those. And then think about an adult with major mental health challenges or substance use and the roles that they have or the roles that they want to have. That's what CORE focuses on, is helping people to identify those roles and be successful in those roles. So it is not intended to take the place of care coordination, home health aid services, or personal care type services. We're not going to do like bathing and toileting or grooming with an individual. If they need that level of care, that's available, but it's not CORE. However, if someone is struggling with their personal grooming and they want to learn the skills needed to work on those things independently, that is something that we could potentially assist them with. So we're not doing anything for the person, but we are giving them the skills that they need to be independent in their functioning. The frequency and intensity of these services is based on person-centered needs. So in our operations manual, if you want to get right into the weeds, we have recommended unit ranges, which basically means that we say about how many hours would be appropriate for a single session. And it does vary by services. Amanda's going to tell you about the service definitions. So CPST, Community Psychiatric Support and Treatment, much more clinical. It's kind of like a mobile therapy service. You're not going to need your therapist for 10 hours a day. So we say, you know, up to about 90 minutes would be appropriate. Whereas peer support, you might need a lot more peer support. That scope is very different than a licensed therapist. And so we say up to about 4 hours a day is appropriate. There's room for exceptions. But I just want to give you an idea of what is typical. And so for most services, we're seeing in-person sessions that last between 90 minutes and 2 hours. Telehealth sessions are a bit shorter, more like 15 minutes to an hour. And the focus, again, is going to be on learning new skills, practicing those skills in the settings where people will need them. So it's not just about, can you do something successfully in my office or even do it at home, but can you do it at the library? Can you do it at work? Can you do it in the community when you're on your own? That's really what the focus is here. So with that, I'm going to turn it over to Amanda, who's going to tell you more specifics about these 4 very important services.
Thanks, Katie, for providing that overview of what CORE is. And now we're going to get into the weeds about what these 4 core services are. And hopefully, as I go through these, you may be thinking of individuals that you're currently working with who may benefit from adding one of these 4 services or all 4 into the wraparound supports that they're receiving in their housing. So first, we're going to talk about Community Psychiatric Support and Treatment, CPST. This includes goal-directed supports and solution-focused interventions with the intent to achieve person-centered goals and objectives. So this is a service component that consists of therapeutic interventions such as counseling and therapy that assist the individual in achieving stability and functional improvement. So this is ideal for individuals who are not able to engage in traditional clinics that would be at like a brick and mortar site. People will come into the community, staff into the community, and meet with the individual in their home or their location of choice within the community. This would be a really great therapeutic option for individuals who are difficult to engage and would definitely benefit from having someone come into the community to meet with them and provide therapeutic interventions for that. The recommended unit range, Katie had mentioned earlier, we have recommended unit ranges, and for each of these 4, we are going to identify what they are. This way you can kind of see what that would look like in practice. So the recommended unit range for CPST is about 15 to 90 minutes per session. And the staff required delivering these services, they are licensed and credentialed staff within their scope of practice. And something to add with the community psychiatric support and treatment, dependent on the staff that are within each agency, there is a health monitoring piece, but it is not to the level of like a personal care aide. Psychosocial rehabilitation, also known as PSR, It's designed to assist an individual with improving their functional ability to the greatest degree possible in settings where they live, work, learn, and socialize. So it's rehabilitation counseling, skill building, psychoeducation interventions that are provided through PSR and used to attain the person-centered recovery goals and valued life roles. So Katie spoke earlier about life roles and what that may be for an individual that you're working with. And PSR is building the skill set behind being able to thrive in those valued life roles. We have a couple different recommended unit ranges. Individually, it's about 15 to 90 minutes per session, and we do have a group option. It is not as often used, but the group session is about 15 to 180 minutes per session. For staff qualifications, unlicensed behavioral health staff, including certified peers under the supervision of a clinical supervisor. So this PSR really promotes independence and full community participation, which is something really valued, so the individuals we're working with aren't just existing in the community, but they're fully participating and thriving. Empowerment services peer support. This is our most popularly enrolled service. And so this is non-clinical peer support delivered services with a focus on rehabilitation, recovery, and resilience, and designed to promote skills for coping with and managing behavioral symptoms while facilitating the utilization of natural supports and resources. And so this provides help from peers who've been there and they know what individuals are going through based on their own personal experience. And so this is really helpful for individuals who have the skills to take the bus, to go food shopping independently, but they may just want the support of someone who understands what it's like to experience that anxiety, getting on the bus and taking the bus down to the store or the laundromat, or just someone to discuss what it's like to navigate through the world while managing different symptoms, having that peer support individual who has that lived experience and practices as a certified peer with their lived experience, it can be really beneficial. And so the recommended unit ranges for this service are 15 to 240 minutes per session. So this is the broadest range of units that we recommend. And that is because peers can help an individual navigate through different life roles. And that may take more than 90 minutes, like a therapeutic session would. The staff qualifications for this role, they are delivered by a certified peer under the supervision of a qualified supervisor. We have certified peer specialists that are designated through the Office of Mental Health. And then we also have certified recovery peer advocates who are certified through OASS, or the Office of Addiction Supports and Services. Which core service would you recommend? And so I just threw at you a bunch of definitions that we have out of our operations manual and kind of the technical pieces, but we provided examples here to kind of get you thinking about scenarios that you probably encounter with individuals in your housing programs and what service with CORE could possibly benefit an individual and help them overcome some of the difficulties and challenges that they're receiving. So we have some animation that's going to come in on this slide. So the first one we have here is, you may hear somebody saying, I'm not making it to my therapy appointments because I'm having trouble leaving the apartment. For this setting, community psychiatric support and treatment may be best. This way they're missing therapy appointments because they're unable to leave the house. So therapy appointments can come to them until they're able to leave their apartment and work towards that. Another scenario is, I want to get more involved with my community through volunteer work. Again, this is that life role. This might be important to this individual, but they're unable to figure out how to get involved or maybe have some apprehension around it. So peer support could be utilized around this, or psychosocial rehabilitation based on kind of how it would be approached. So peer support would be, I'm really looking for someone to come with me in this volunteer work. I've identified where I want to volunteer. I'm just apprehensive about going into a new situation alone. Peer support would be ideal. And for psychosocial rehabilitation, it may be someone who previously had volunteer experience. It's important to them, but they want to work on socialization skills. They want to practice taking public transportation to the volunteer opportunity that they may have. So for this, it could go both ways depending on the actual need of the individual. And that's where the person-centered piece comes in. It's really specific on how the individual, what the supports are needed to get to the volunteer work. Another situation we have is I want to finish my degree. So psychosocial rehabilitation. Through psychosocial rehabilitation, we do have two individualized components. We have an educational component, and this is for individuals who would like to obtain their GED, their college degree, a trade, as well as a employment component. And with the employment component, this helps individuals obtain employment of their choice. And so wanting to finish my degree, that would absolutely fall under psychosocial rehabilitation, helping an individual be able to apply for some financial aid, determine what type of degree they want, help them learn how to research where the best program is in their local area for the program degree that they're interested in. It is not completing the application for them, completing their resume for them. It really is just providing additional support to an individual as they navigate the process to getting to finish their degree themselves. I'm having difficulty maintaining my apartment and I want to implement better routines to prevent eviction. I'm pretty sure this is a common occurrence within housing. It's just helping individuals maintain their living spaces, whether it be for health and sanitary reasons, but also potentially avoiding eviction and maintaining the existing housing that they do have. And so for this, we recommend psychosocial rehabilitation. It will help an individual gain the skills, habits, reinforce the skills and habits. And so with housing, we understand that you have large caseloads and you may not be able to assist an individual every week with maintaining these skills that you've already been going through with them. So psychosocial rehabilitation staff can come in and reinforce the skill sets that you're already working on with individuals in your housing programs. My family doesn't understand what I'm going through. So for family support and training, is the family of choice that an individual has, and really helping that family of choice, whether it be blood-related family or very close friends and community supports, church, different areas where they receive their supports in the community. Family support and training is meeting with the individual if they choose to end their family of choice with proper consents to really help the family understand what the individual is going through, how they can, how to best support an individual who is experiencing symptoms. And the real kind of drive home with family support and training is helping individuals maintain that natural support system outside of people from the mental health system coming in and providing that support. And so family support and training is really ideal for individuals who have family that just don't understand, or maybe an individual wants to strengthen some of the natural family relationships and relationships in their community. And so it really provides training to the family to help best support that individual. And so this is only done with the consent of the individual, and the individual can be present or they may choose not to be present, but it is geared towards family and family of choice. And so this would be a great example for if someone says that their family doesn't understand what they're going through, this would be ideal. And it could be, in terms of housing, it could be a roommate doesn't understand, or a parent is having difficulty understanding, a sibling. So family support and treatment would be ideal for this. I get so anxious riding the bus, it makes me not want to go anywhere. Psychosocial rehabilitation would be ideal for this if the individual needs assistance with developing the skill set to be able to take the bus independently. And we also added peer support here as well, in case the individual has that skill set to be able to take the bus. It really is just the anxiety while riding the bus that makes it challenging for them to take the bus anywhere they would like to go. So both options are there. I want to reconnect with my church faith community. We put peer support or psychosocial rehabilitation here. Peer support, it could be an individual who is also a member of a particular church or faith community who also has experienced mental illness. And so peer support could help integrate the individual into choosing their church and faith community. I want to get a job. And so that is the psychosocial rehabilitation component here. And so we just threw a lot of information at you, and I just want to take an opportunity to see if there are any questions. Just for some housekeeping, we do have a question and answer towards the end, but just wanted to take a break in case there are any questions that are already being asked.
Yeah, thanks, Amanda. We do have a number of questions that have come through. So I'm going to go through most of them. There are some questions that folks put in the Q&A around referral and eligibility, and that's actually the next section that we're going to go into. So I'm going to hold off on those questions in anticipation that they'll be answered in our next few slides. So the first question we have is, oh, and one more thing. I just want to make a plug for everybody that does have questions. Please make sure that you put them in the Q&A. There's a little icon at the bottom of your screen that says Q&A with two like speaking bubbles, and that's how you can answer the question and answer. If they're being put into the chat, I'm just afraid they'll get lost in the shuffle. So the first question we have is, can you explain more what a unit means for the units of time?
Yes. So a unit is, it's essentially 15 minutes. And so in terms of billing, we outlined what would be our recommended. So the unit is 15 minutes. And so when we say 1 to 2, 1 to 4 units would be essentially 15 minutes to 1 hour. The unit is just a kind of a metric of billing. And so 1 unit is 15 minutes. And then when we say 1 to 4, that essentially would be 15 times 4. So that would be the 1 hour. So it's really just a unit of billing. You'll notice that even though unit was on the slide, I actually said the minutes, because for us, units make sense. But in terms of housing, you want to know how many minutes an individual would be receiving that service. So, but that's a great question.
And I just want to jump in and say the reason we're even telling you that level of detail is because we know that there are some people who need close to 24 hours support. And we just want to be honest and upfront that that's not what this is. So we want you to really get a sense of what the scope is that's available.
Great, thank you. Can you talk a little bit more about how you're defining certified peers and peer advocates?
Yes, so certified peers and peer advocates are certified through Office of Mental Health and OASAS, and they go through the formal training to become a certified peer, or they may be provisionally certified to provide those services. Katie, I don't know if you wanted to speak more to that.
Yeah, well, so I won't speak too much to the OASAS side because we don't have them on, and I'm not an expert in how their peer certification process works. For us, individuals who identify as peers with lived experience would go through the Academy of Peer Services, or APS. As of now, it's a free online training, but it's pretty intensive. There are many, many modules, hours of training, and then they are eligible once they complete the trainings and pass the exams. They're eligible for a provisional certification. Then they need to get their supervised hours before they're fully certified. CORE can be provided by those individuals with provisional certification. So for us, that would be a CPS, or Certified Peer Specialist. On the OASAS side, their training is a little bit different. It focuses obviously more on substance use and addiction. It is the CPRA, or Certified Peer Recovery Advocate. They also have a provisional credential that's allowable for peer. And so because these are Medicaid billable services, we do need them to be provided by individuals who are certified.
Thanks. And then is there a distinction between certified peers and peer advocates, or are those used interchangeably?
In this presentation, we're using them interchangeably.
Okay.
Certainly peer advocate, I would say, is more of a global term that you might hear, but if we're talking about it in the context of peer, it would be someone who is certified.
Okay, thank you. And then a couple more questions about peers. Are they currently offering face-to-face visits?
Yes.
Fantastic.
Yes, they are.
Okay, and can family support be done with a peer?
Yeah, so peers are actually qualified to deliver psychosocial rehabilitation, family support and training, and peer support.
Okay, thank you. Let me see, these are eligibility questions. Is pharmacotherapy offered in CPST?
It depends on the staffing that the designated provider has. And so some designated providers will have a psychiatrist who could prescribe, and some do not. So it really would be getting very familiar with who the providers are in your area who are designated for CPST, and reaching out to them to see the different components that they do have available within their program.
Yeah, I would just add that as of the time we're doing this webinar in early 2023, the vast majority of core providers do not have a psychiatrist or psychiatric nurse practitioner available to prescribe through CPST. We do allow co-enrollment with an outpatient clinic if someone wants to get their therapy and counseling through CPST, but their meds through a clinic, that's allowable. But certainly call the local core CPST providers in your area. There are, I want to say, maybe 3 or 4 that I'm aware of that do have a prescriber. So very variable.
And that list we're referring to will be shared towards the end. It's a link that's on our website.
Okay. Do we have time for a couple more questions?
Yeah, I would say 1 to 2.
Okay, great. Can you talk a little bit about the difference between MRST and CPST? And how those things differ?
MRST is not an acronym that we're familiar with. So if whoever asked the question wants to spell it out for us, we can try to answer it. But that doesn't sound like a service that falls under my team here at OMH.
Okay. All right. So if the person that submitted that question could give a little bit more.
It looks like they've put in mobile residential support team.
I am not familiar with that as something that's available as a statewide service, so it might be something that's local to your community. But if you want to follow up with us via email, we would be happy to look into it and try to get you more information. So our email is provided at the end of this. It's core-services@omh.ny.gov. So that would be something I would just need to research more before answering with any level of confidence.
Alrighty. And then are core services offered through licensed OMH programs? And if so, can they be offered through a licensed supportive housing program? I don't know if we'll get into that a little bit later.
So core services itself is not a licensed OMH program. That different programs receive full designation. However, these can be brought in as a wraparound support to individuals who are in supported housing. I hope that answers that question.
Yeah, if I can just add to that, these are standalone. So the designation to provide core services is at an organizational or agency level. It's not like it doesn't get attached to a specific program. Now, how your agency operationalizes that might be different, but as far as how OMH sees it, Fountain House is designated, not the Fountain House Clubhouse, not the Fountain House Employment Program, but Fountain House as an organization is the designated provider. So certainly an agency that has licensed housing could also be designated for core services, and then you could provide those in your licensed housing, but they would be separate.
Okay. And what is the reimbursement rate per service?
So the reimbursement rates vary, and we have billing guidance that can be shared at the end. That level of detail is not currently presented in this presentation, but we do have it, and it varies by each of the 4 services.
Given that I think you said it's possible to engage in these services via telehealth, if folks have, family members or chosen family members that are living out of state, would family support and training still be a viable option for folks in this situation?
That's a great question. I see Katie shaking her head yes, so I'm going to call on her.
Yeah, as long as the individual is a New York State resident and has the correct type of Medicaid, which we'll talk about, but if the individual themselves is a New York State resident who is eligible for core services, then yes, their family, who we officially would call a collateral contact, their family of choice does not have to reside in New York State.
Okay. Okay. And then can you, go ahead. Do we need to move on?
I think we should maybe continue.
Okay.
On.
Yeah, absolutely.
But lots of great questions coming in, and we will get to them.
Thank you.
Thanks, Lauren. So core access and eligibility, which we already know is a popular question that has been asked, and hopefully as we go through these next few slides, that will answer them for you. And so increasing access, no wrong door. And so core services, these 4 services used to be under the adult BH HCBS services. And as of February last year, they transitioned over to core. And so core is an 1115 demonstration of rehabilitation services, what we're also calling the rehab option. And because we moved these 4 over into the rehab option, it allowed us to remove the federal HCBS requirements. And so those who are familiar with HCBS may know that there was a workflow process to be able to make a referral to these services. And so through core, we've reduced the barriers to access. And so there's no final rule restriction on where people live and receive these services. So individuals who are in community residences, a congregate setting, adjacent to a psych center, hospital, previously would be ineligible for these services because of the CMS final rule. And so that has been removed. Referrals can also come from anywhere. And so with housing, you may be very familiar with SPOAs, and with these referrals, you do not have to go through SPOA. On the next slide, we'll definitely show the different referral sources that can refer to core, but they can come from anywhere. There is no SPOA to kind of gatekeep where the referrals are going. No level of service determination process prior to the referral. The eligibility is based on HARP MAP status, plus an LPHA recommendation, which is a licensed practitioner of the healing arts recommendation, which we will go over in a few slides. And then agencies can make internal referrals to core when appropriate. And so when we say no wrong door, we truly mean no wrong door. And so these are the various different pathways that can send over a referral to core services. And so you'll see housing provider in that bottom right, but there's friends and family. Self-referral, if an individual hears of these services, they can reach out to a local provider themselves, local provider of core services, and reach out and discuss what might be a best option for them. We have core peer navigators in the different regions throughout New York State. They're helping connect individuals to core. Referrals come in from the MCO health plans. They can come in from SPOA or someone who's coming off of an ACT team, care coordination, hospital inpatient units, and clinicians. And so there really is no wrong door. And the great part about being able to remove the barrier is as long as somebody is eligible, these services can be accessed in a larger way. And so the benefit of this is individuals are receiving these additional supports through CORE when they need the assistance. And so this really reduces the wait list or wait time between an individual determining that they do want CORE services and actually receiving an intake and evaluation. Eligibility for CORE services. And so eligibility criteria is enrollment in a health and recovery plan, also known as a HARP, or an HIV special needs, also known as a SNP. You would look for the RRE codes H1 or H4, or if an individual is part of a Medicaid Advantage Plus plan, that is a new CORE carve-in for MAP enrollees that began on January 1st of this year, 2023. So you would need this as well as a recommendation by a licensed practitioner of the healing arts. And we are going to go over that. Who are HARP members? And so when we talk about HARP members, the subset of the Medicaid managed care population, who are these individuals and why have they been identified for HARP? And so HARP members are identified using two algorithms that the state runs every 2 months. And so first, these individuals are Medicaid enrollees, ages 21 and over, with a mental health or substance use diagnosis, and they must be enrolled in a mainstream managed care organization and cannot be participating in or enrolled in an OPWDD program. So once you've established the above info, the algorithm looks for specific HARP risk factors that indicate the person would benefit from an enhanced service package. Some examples of these risk factors include SSI recipient who's received a mental health service, 3+ months of ACT or PROS in the last year. We do have some duplication of billing identified for ACT and PROS. So for ACT, an individual would need to come off of the ACT team and enroll in CORE services, and for PROS, they can enroll in the peer support component of CORE. Recent history of psychiatric inpatient hospitalization in the last 3 years, current or expired AOT order, residents of OMH funded housing last 3 years, recent history of substance use disorder detoxification, inpatient and or SUD related ER visits. And so we've pulled some examples in, but the actual full list is located on DOH's website. And so the list above is just illustration purposes only that may relate to individuals who are in housing who you're currently working with. And so HARP risk factors are determined using the behavioral health high risk algorithm. And individuals meeting these criteria are identified every 2 months with an H9 code. And so we really are focusing on individuals who need the enhanced benefit of these supports and are identified through HARP. So HARP members in New York State. So there are approximately 166,200 New Yorkers with serious mental illness and substance use that are enrolled in a HARP. And so the benefit of these individuals who are in HARP or considered HARP eligible are integrated mental health, substance use, and physical health services. It's an added suite of behavioral health, rehabilitation, and recovery-oriented services, and increased engagement for HARP members who are disconnected from traditional behavioral health systems. And so with these services being provided in the community, it is able to establish engagement with individuals who would traditionally be not engaged with traditional behavioral health. And when we say traditional, we mean physically going to a location like a clinic. CORE can also be used as an engagement tool that can open the door to mental health and addiction support services for an at-risk population. And so how does this relate to housing and residential programs? So there are approximately 14,000 HARP members residing in OMH housing and residential programs. And so It's a great amount of people that could be potentially receiving these additional supports, like a wraparound support. There are 21 OMH housing providers with over 200 plus HARP members in their housing and residential programs. And so Nicole will speak later. Fountain House is both an OMH licensed housing provider and a designated core provider as well. And so she'll speak later about how core and housing connect within her agency. And so residential and supported housing providers, you could also be designated for core services, and this can complement the tenancy support services that individuals are already receiving through the housing program. Residential and supported housing providers can also refer out and collaborate with local providers for core services. And so each core provider is designated for each individual core service. And so you may have core designated for your agency, but it may not be for all four. And you may be essentially quote missing maybe one of the core services that an individual is hoping to receive. You could network and collaborate with other core service providers in your local area who are designated for that service to be able to refer out to them for that. And the great thing about this is core staff can reinforce skills and information taught in other program models. And so a lot of the support that is being provided through housing programs, core staff can come in and help reinforce the skills that you're already working on in a capacity that housing staff may not have the margin to provide these services for hours every week. A core staff could come in and assist with these services. And so with this, I'm going to pass it over to Katie, who is going to go through how to identify who the HARP members are in your programs.
All right, so as Amanda said, these services, they're wonderful, but they are limited to a certain set of Medicaid managed care enrollees. And because those individuals are identified using an algorithm, you can't refer someone into a HARP. Or into an HIV SNP or a MAP plan. So how do you figure out which individuals in your housing programs might already be eligible for these services? There's a few different ways. Unfortunately, none of it is super easy, but I'll go in order of easiest to hardest. The first one is check psyches, if you have access to psyches. So psyches offers you access to clinical records for individuals with Medicaid and serious mental illness. Many of our OMH housing providers will have access to psyches, or someone in your organization will. So you can run a report in psyches, and I'm going to show you a couple of screenshots from that. But individuals with mental illness or addiction disorders can also pull up their own data using an app called My Choice. So if you just Google psyches, that's PSYCKES, My Choice, it'll come right up. The individual will need to make an account. It's all their Medicaid data, so it's very secure. They would need to contact OMH to get a username. But in theory, any individual who resides in your housing should be able to do this. That would be on a one-on-one basis. So again, it's not very easy, but this is one way you could check. If you have access to ePACES eMedNy, you can also run a report. So if your organization is a Medicaid provider, you could run a roster report for the individuals in your program to check their H codes. And lastly, you can check with the individual's managed care organization if they have a copy of their Medicaid card, their managed care card. That could tell you. You can call the MCO directly to find out. You can also call New York State Medicaid Choice run by Maximus, and they can tell you. So again, I always prefer the website, being able to run a report versus having to make phone calls, but you've got a couple of different options. I would say that the very last option could be to contact a core services provider and just make the referral anyway, and they can check eligibility. So a few different ways for you to look into this. Okay, next slide. So I'm going to show you a couple of screenshots. We created a new feature in Psyches. So if you're familiar with Psyches, this might look familiar to you. This feature should go live the first week of March, and it'll actually flag for you core eligibility. So you won't have to interpret what an H code is once this flag goes live in early March. Psyches will also be offering training on how to run this report, but here you see the recipient lookup, and so you could run a report to see who's core eligible. Next slide. Here you also see where you can pull up someone's clinical summary. So you could run a roster report for your programs, and then you could look at their clinical summary to see if they're core eligible. So I am not a psyches expert. I won't go into too much more detail about this, but just to note that we are creating that core eligibility flag for you. Okay, next slide. So we've mentioned probably at least once or twice the LPHA recommendation. So in addition to being in the correct type of Medicaid managed care, we also need a recommendation from a licensed practitioner of the healing arts to say that yes, this individual would benefit from rehab services. So this is all about medical necessity. We have a very simple standardized form that's available on our website and linked here. Any licensed practitioner of the healing arts can complete the form. So it could be someone at the core provider, it could be someone in your housing program, it could be a primary care doctor or a therapist in the clinic. But basically anyone who's in a position to be able to say that this person, yes, would in fact benefit from core services. So two pieces there that are important. Number one, they're in the correct type of managed care. And number two, they have the LPHA recommendation. Now, we have encouraged all of our core providers to have an internal LPHA, meaning that all they need is to get a referral and that LPHA would be able to complete the paperwork. It's not universal, but I would say most of our core providers at this point do have that ability to do the LPHA recommendation. So if you are a housing provider acting as a referral source, you want to refer someone to core services, don't let the fact that they need an LPHA recommendation stop you from making that referral. Don't say like, well, we don't have an LCSW who can sign off on this. We don't have a nurse who can sign off on this. Don't worry about it. Send the referral anyway. The core provider can worry about getting their own medical necessity documentation done. Okay, next slide. So just to give you an idea of who LPHAs are, because I know that some housing programs do in fact employ licensed social workers and mental health counselors. So what we're looking at is basically your nurses, doctors, physicians, physician assistant, nurse practitioner, psychologists, that would be a licensed psychologist, licensed mental health counselors, creative arts therapists, marriage and family therapists, and psychoanalysts, and then of course your licensed clinical social workers and licensed master social workers or LMSWs with appropriate supervision. One thing I will note is that limited permit holders for the mental health counselor, creative arts therapist, marriage and family, and psychoanalyst, if they just have that limited permit, they're technically not licensed, and so they cannot function as an LPHA. But if you do employ any of these individuals, they could sign off on that medical necessity paperwork. Next slide. So I just want to highlight the differences between a referral and a recommendation because this has been really confused in our system. I know that on the children's side, they've come up against this as well. So these are two different things. I know they both start with an R. Referral, this is basic. This is intuitive. You've been making referrals your entire career. Anyone can do it. It's really just that simple process of connecting or linking someone to core services. It's a matter of, in most cases, picking up the phone, maybe filling out like a page of demographic data. It's going to be a little bit different for every provider. Some might ask you for more information than others, just like if you were referring someone to a clinic, you're going to want to connect with the provider directly and say, hey, we want to make a referral. What's your process? So that's really simple. LPHA recommendation can only be done by a qualified licensed practitioner of the healing arts, practicing within their scope of practice. It's a standardized form, so for every core provider, it's exactly the same. And it's completed at some point during that intake and evaluation process for core. So they don't need it on day one. They have a little bit of time to get to know the individual and obtain that documentation. So for most people listening to this today, I just want you to focus on that green column, which is the referral, and know that it really is a very easy process once you've identified a core provider in your area. Okay, next slide. So a very quick recap before we move on. Core services, we told you there's CPST, family support, peer support, and psychosocial rehabilitation. We do have the ability to offer employment and educational focused services through psychosocial rehabilitation. So if someone has a work or school related goal, we can support that. It is specific to the HARP population and some MAP or Medicaid Advantage Plus plan enrollees. So it's a targeted audience, but still it's a large targeted audience. It's 166,000 New Yorkers. We've removed a lot of the barriers to access if you were familiar with adult behavioral health home and community-based services, which rolled out in 2015, 2016. So basically the takeaway there is that core is a lot easier to get into. And if you were familiar with home and community-based services, as a housing provider, you may have been concerned about some of the CMS restrictions on housing and residential providers. None of those apply to core services specifically. So you don't have to worry about where the individual lives as long as they have the right type of managed care and the LPHA recommendations. Their residential or housing setting has no impact on eligibility. All right, next slide. I think we're going to pause for maybe a few questions, like maybe no more than 5 or 10 minutes.
Okay, all right. So one question that seems like it would be worth clarifying for folks is, can you explain what you mean by licensed housing when we're referring to licensed housing?
Yes, so licensed housing would fall under community residences, apartment treatment programs, and I'm not as familiar with where supported housing lands right now, but I believe you're also licensed for supported housing. And so licensed housing through OMH would fall into that category. You'd have an operating certificate to provide housing.
Thanks for that clarification. One more clarifying question. A person cannot receive both ACT services and core services, is that correct? Or can they receive
Correct,
both?
yes. So it would be considered duplication of service to be enrolled on an ACT team and also receive core services, because there's a lot of very similar components within how the services are provided. And so if you have an individual that you're working with who is on an ACT team and may be ready to step down off of ACT, but maybe still really wants therapy provided in the community, or wants peer support to kind of just provide additional support through that transition off of an ACT team, core would be a really great step down from an ACT team into a different program that would not have as intense services like an ACT team.
Mm-hmm. Okay, and then there was another question about, is this more for folks that are living in supportive housing versus folks that are living in the community on their own? And noting that this person works with folks that are 55 and up living independently. However, many of their folks are really struggling with substance use disorders and mental health challenges and would benefit from core services. So would they be able to access core?
They would, yes, as long as they meet that HARP or MAP or HIV SNP eligibility and have the ability to have that LPHA form to document the medical necessity, which could be taken care of on the core providers end. Yes, so we're speaking supported housing in terms of licensing, and we're very familiar with OMH world and housing. And so that is why we keep saying that. But yes, if you're working with an individual who is living independently in the community and meets that criteria, absolutely make a referral if you feel that they would benefit from any of these 4 or all core services.
Okay, and I'll just do one more question. Is a designated agency required to provide all 4 services?
They are not. And so we have providers who are designated for all 4, and then we have providers who may be designated for peer only, or PSR and peer, or maybe family support and training, PSR and peer. So they're not required to be designated for all 4. However, on our designation list that we'll share at the end, it identifies what provider is designated for which services in which counties. And so if you were to look across, it's an Excel spreadsheet. And so if you were to look across, you could see which providers in your local area are provided for all, designated for all 4 of the services and what counties those designations are in.
If I could just add to that as well, if an individual wants services that a single provider doesn't have, say someone wants all 4 services, but they have a really strong connection to a provider that only does peer, they could get their peer support from one provider and the other services from another. So you don't have to pick only one core provider. Now, you can't get peer support from 2 separate core providers, but you could get peer at one agency, psychosocial rehabilitation at another, community psychiatric support and treatment at another. So if there's an agency that doesn't offer all 4, I wouldn't say like avoid that agency by any means. They're probably really good and really focused and just know what they excel at and have chosen to deliver only the services they're really, really good at. And so you might be referring to multiple core agencies in those cases.
Thank you, Katie, for clarifying that. That is really important. And it also speaks to how CORE is not a comprehensive program model. It's a la carte. And so that is the ability to look at each specific service individually, and you could make referrals to several different core providers.
All right. Thank you.
Okay, so it looks like that's it for questions, and we'll have another question and answer part towards the end. And so now I'm going to go into CORE and housing residential. And so CORE and housing status. So not all housing residential service recipients are going to be eligible for CORE services. If they don't meet that HARP eligibility, unfortunately, they would not be eligible for CORE. However, for those who are enrolled in the right type of managed Medicare plan, there are no restrictions on where an individual may receive these services. And as we mentioned before, this is a change from that BHHCBS rule where there was a restriction on settings rule. And so with that being removed, it's really opened up the ability to provide these services to individuals who would not have been eligible to receive these services under that settings rule. And so additionally, there's no restriction based on homelessness, sheltered or unsheltered. I will say traditionally, we have not seen the homeless population. There's not a great amount of number of individuals who are HARP eligible just based on providers who have gone out and tried to do outreach into those areas. But there is no restriction based on sheltered or unsheltered homelessness. Value added for housing residential programs. And so we've thrown all this information at you and just wanted to highlight some of the areas on how this can be a value add for you as a provider of housing. So peer support during appointments, and that could be at DSS, the DMV, doctor's offices, and assistance navigating systems. And so with the size of some housing providers' caseloads, there is not enough time to be attending several doctor's appointments or, maybe spending time actually physically navigating a system or method of transportation to get to these appointments. And so peer support could be an additional support to wrap around that individual. And then there's also skill development. And so this can be around budgeting, basic living skills, the employment and education components we discussed, and also helping individuals work towards the skills that will help them attain more independent levels of housing. And so for that, we would recommend the PSR. And then mobile counseling therapy and med management services. And this is for individuals who are really difficult to engage and are disengaged from that traditional mental health piece. And so if you have an individual in supported housing who is really independent, does really well in the community, has a solid skill set, but just does not like going into the community specifically for counseling and therapy services or med management services, this service may be best for an individual to help engage them in treatment while also maintaining that level of housing. And then for individuals and family supports during the transition out of a community residence. So going from a community residence into maybe an apartment treatment program or supported housing, there's a lot of new experiences transitioning out of such an intense congregate setting into a more independent setting. And so peer support, PSR, and family support and treatment, family support and training can assist an individual with having the additional supports that they need to be successful in that next level of independent housing, while also strengthening the skills that they're working on with the housing individuals that they're working with. So core services and housing, designated providers are encouraged to explore how service bundles might plug into their OMH OASS license or funded housing models to meet unmet needs. And so we've discussed how core is a la carte. Each individual service is its own standalone, which is all true, but you can also what we call bundle these services. And so if you took family support and training and peer support, you could bundle that together to support an individual who was recently discharged from inpatient and is now in a community residence. Another bundle you could do is PSR plus peer support could reinforce skills and information taught in apartment treatment programs. And then you could bundle all four, CPST, PSR, peer support, family support and training as a wraparound support to work towards stepping down from supported housing. So individuals who may have obtained a voucher, subsidized voucher for housing, and we transition off of supported housing, it can provide them the additional support that they need while they're in supported housing, but then also as they step down from supported housing and into a more independent setting, which kind of speaks to the question earlier about individuals who are just living independently in the community. This would be great for that. We have a flexible service design. So these services can be bundled to meet special need populations. And so we spoke earlier about ACT team step downs. It can also work well for young adults, individuals with forensic involvement, and also as a hospital step down critical time intervention approach. So it may be someone who was in the hospital recently and is now being discharged back to their housing. And this can work as a temporary additional support as they transition from the hospital back into their housing. And so agencies can implement a team-based service package using clinicians, peers, and psychiatric rehab practitioners. Another added benefit is through CORE being under the rehab option, communication between collaterals is also billable under CORE services, whereas before these services, that was not billable. And so that is also an added benefit in terms of just having open communication with collaterals. And so with this, we've asked Nicole Pickett, who is the Director of Managed Care at Fountain House, to discuss how her agency is implementing core services into their supported housing programs. And so I'd like to pass it over to Nicole.
Hi. So again, my name is Nicole Pickett. I have had the great pleasure of working at Fountain House for 27 years. Worn a lot of hats in those 27 years, but one of them, I worked in housing at the beginning of my career. So I really know firsthand the heavy workload that y'all have. And I would have dreamed to have core services to be able to refer to when I was working in housing. So you can go to the next slide. So Fountain House has provided, we were first in HCBS and then in cores starting back last February, and we are designated for psychosocial rehabilitation or PSR and peer support services. Our staffing, we have decided we had separate staffing at one time, but we really have a full peer workforce and they are credentialed to do both of those services. We have housing as well. We have a fairly large housing program. And so we partner with them to educate them about core services and to identify individuals who are in all of our levels of housing to identify non-duplicative supports. We're not looking to replace what housing supports are there. We're there to add to it, to enhance it, and to try to give each of our members the support that they need to either stay in the level of housing that they are, if they're having a setback or having some more supports that they need, and to lift some of the burdens of our housing staff. We go through all of a list of our many people to determine the eligibility through looking at EPASIS, and we look for those age codes in EPASIS. When we get outside referrals from other organizations, we kind of do that lifting for you. If you have somebody that you're not sure is HARP eligible or is eligible for these services, we'll go ahead and look them up for you to find out if they are. We also do direct outreach to individuals that may be in need of services to see if they're interested in core services. And we look throughout the agency, not all in our housing program. Our housing staff are very aware of what that referral pathway looks like. It is a simple phone call. We have a form that's you can fill out, but you can just call and we can get the process started for you. We're really, I think, the barriers that HCBS had in place with cores, there's not all those barriers. So we're trying to make it as barrier-free as possible, both for an individual who wants to refer themselves, heard about core services and are interested in receiving them. But we also want it to be a low burden for our referral sources. I said the folks that really benefit from core is folks that wish to stay in their housing if they're having a setback, that maybe need temporarily higher supports, helping people to learn or regain skills to live more independently. Let's see, I'm just going through my slides and making sure that I covered everything. I think I did. One thing that I will say is that I think that the core services have really helped folks that receive them have much more positive outcomes. So they've been really, really effective. So you can go to the next slide. So in psychosocial rehabilitation, again, we're helping people to learn or regain skills to live more independently or reach their potential. We help people to successfully find employment. That goes from learning how to write a resume. One thing that I say all the time is that we're not a do for, we're a do with program. So we're really helping people to learn skills themselves so that can be transferred on later in their life. So helping people to find employment. We help people to apply and enroll in school, access student services, apply for financial aid. We do a whole lot of helping people with housing applications, preparing for housing interviews, budgeting, health and meal planning, organizational skills at home. And again, in the home, it's really where, our core staff don't go and do the things for folks. It's really helping to support them to learn the skills to be able to do it for themselves. For peer support, we do a lot of work in helping people with socialization, community integration. A lot of times there's goals for folks that's like, I want to have more friends and I want to be more integrated in my community. And that's a great place for peer support to come in. We do a lot of support in traveling on the subway systems, getting to and from appointments, and people who have anxieties around the subway systems, especially today and after the pandemic. That's been really helpful. And from the peer perspective and having somebody who has a mental health condition themselves, it's really been a powerful set of supports. We help people after a hospitalization, going from a hospitalization back into their housing. Learning technology, that was a big one over the pandemic because of everything kind of going virtually, helping people to learn the skills on a smartphone or a tablet to connect to their doctors, and and just all the stuff needed to attain benefits. Those are some examples. I think the one thing that is important to know is that these services are really, really flexible. They, I think that you can think about any goals or any additional supports that people need, and it can probably fit into one of those 4 categories of core services. Some success stories. We have many, many success stories. I pulled out 3. So the first one is she experienced an increase in social anxiety. She began to really isolate at home, was really not leaving home at all. She wasn't doing her laundry. She wasn't going to the grocery store. She was spending all of her money on takeout food. So then she had major budgeting issues. She was a member of our clubhouse as well, is a member of our clubhouse as well. And so she was not connecting to the clubhouse and coming in. She was on occasion connecting virtually, but she really had a hard time riding the subway by herself, and she had great anxieties about doing that. So she was enrolled in peer support services and psychosocial rehabilitation. We, on her ISP, we had identified about 2 hours a week. And I think, I know Katie and Amanda talked about all the units. There's some recommended times, but it's really based on people's needs. And so we allotted for 2 hours. Sometimes it went over, sometimes it was under. So there is flexibility there. We had our core staff going to her home and helping her with sorting the laundry and taking the laundry to the laundromat. And while at the laundromat, they were doing budgeting and figuring out meal planning. And then on the opposite weeks, they would go to the grocery store, make a grocery list. And that really helped her to get used to getting back out there and reducing those anxieties. And it was really beneficial for her to have someone to do this with her and to help her throughout that. In addition, they started going to riding the subway together, getting her to the clubhouse, traveling back and forth, and then eventually kind of tapering that off once she felt comfortable to do one way on her own. And then she was able to start coming into the clubhouse independently. So that's one example. The next example is an example of psychosocial rehabilitation with employment focus. So M he was working independently for many, many years in a mailroom. He lost his job during the pandemic. And when he was ready to find another job, he didn't know where to start. He hadn't done that for a long time. He was not interested in going to a program. He was not interested in and doing all of that. So core services really was a good place to start because we were able to go to him. And so he and his core staff met at a local coffee shop. And I think that they met weekly, sometimes a little bit more than that, to start updating resume, signing up for online job sites, filling out applications, preparing for interviews. The core staff would, even before the interviews, he had a couple and he was hired, and they met him before the interview, traveled to the interview, waited after the interview, and then supported him after the interview. Matt is now working at a local Meals on Wheels doing deliveries. And so he's now employed. So it's a great success story. The next and last is Jay. She had been and happily still is living independently. She had been for many, many years. She was recently diagnosed with a serious medical condition, and it required so many appointments and follow-up appointments. And her housing staff, it was just too much for any one load. So she really wanted somebody that she could relate to, that wasn't a clinician, that would go to those appointments with her. and help her to remember what the doctor said, help, write things down. So they worked very closely together while she was going through this really challenging time. She was also worried that in all of the treatments that her mental health would decline. And so she and her peer specialist worked on a RAP plan so that if that did happen, that they were able to, act quickly. And it was really centered on what she would want. And so that was, I think, really an important piece to her services. And she is doing extremely well. And she's been discharged from core services, and she got through all the treatments and was very successful in that. So these are three of examples of many that have been worked really well for Fountain House.
Thanks so much, Nicole. And what I think is really great about some of these examples, just in addition to the success that they are and how they were able to receive the support that they needed, it also shows the flexibility. This was a season of life where Jane needed additional support. She was able to receive it and then was able to discharge from core when she no longer needed that additional support. And so I think that's also a really great example of the flexibility. Thank you so much for sharing those success stories and how core works for Fountain House. Wanted to share some resources with you as we head in towards the end. And this will be where links are and email addresses. And so before we get into that, just a quick case example. The success stories that Nicole shared definitely speak to how core can look in practice. We have a case example here that we created. And so Riley's an individual in supported housing apartment in an urban setting, recently having increased anxiety. So this is very similar to the success stories that Nicole had shared. And just showing how a peer specialist met with them. They rode the bus together at any time, as the bus went down the line, there was more individuals coming onto the bus, became very crowded. And in a situation where Riley would normally get off the bus because it was just too crowded, the peer was able to start discussion with her, talk about favorite recipes to cook, and really helped them navigate that social anxiety with being on a very crowded public bus. And so they would ride to go shopping together and then ride the bus back. And they made plans to do this every Saturday for the next couple weeks. And so when making that connection to core, to be able to make this connection, the housing provider ran the psyches report and identified this individual as a HARP enrollee. And as a HARP enrollee, they were eligible to receive this service. So really just a case example to kind of demonstrate, this is the scenario, but then if you're noticing this, how do you make that connection? Finding a core provider near you. And so the designation list is available on our OMH website. It's updated daily. So any updates to contact information for core providers is captured daily. And so the link will be here. And once these are shared, I believe you'll be able to click on these links. But I'm hovering over just in case. And so the designation list, we have two. One is specific for New York City. And then we have what we are calling the rest of state designation list. And so New York City has our New York City designated core providers. And then for the other counties outside of the 5 boroughs, they would be on the rest of state designation list. We also have OMH hosted providers added to our Find a Provider search function, which is also on our website. We say OMH hosted because we do have some providers that are primarily providing these substance use disorder services through OASAS. And so on the OMH website, we have that Find a Provider function. And so when you use that search, you would search by county. Depending on how you select the search, the core providers would pop up on that as well. For New York City, this is the core provider list for New York City. This is a much abbreviated version. It just mentions the providers in New York City. And this list is current as of February 6th. And so this is just to show which providers are designated for any core services. And the designation list would have more specifics on which services these providers are designated for and what boroughs, counties they are designated to provide the services. And so providers are designated by the 4 core services that they apply for, but they also are designated by county. And so some providers, serve all 5 boroughs. Some providers will only serve 1, and that's located within the designation list as well. And just a kind of caveat, we're reviewing this on February 15th, 2023. And so the list here, it's subject to change and was shared just to, as an intended resource to kind of help get you thinking on, some local providers that you may already be working with or are maybe part of yourself. And the designation list should absolutely be used as source of truth for who is designated to provide core services. And so just thinking about what opportunities do you see, what are the unmet skill development needs for people in housing? How could a core practitioner improve outcomes and quality of life for individuals in housing? Trying to think about how peer support can help people in supported housing and how these services can work together to help individuals. Where might people in housing programs find core services internal to your agency or within the community that you're providing services in, that they're living in? And what would your next steps be as a housing provider? And so when we open up the discussion part, the question part, just some things to think about if you wanted to add to the discussion. And the technical assistance piece. And so we have been providing a lot of recordings related to CORE, and they are housed on the MCTAC website. They have a CORE Special Initiatives page that is dedicated to all of the resources that we have recorded and provided for MCTAC, as well as some that they have done internally as well. And so the link for here has the location for all of those recorded webinars. And this was really a CORE 101 kind of overview. The webinars that we've done on the MCTAC website, they are specific. There's an entire 1-hour presentation on each one of the 4 services. We also talk about CORE, with care managers and just community providers in general. And so lots of information on there. Emails, as we were talking about earlier. And so for technical assistance related to core services, for OMH, we have our new website here, our new email address, I should say, is coreservices@omh.ny.gov. And then for providers who may be more substance use disorder focused, OASAS, pick'em@oasas.ny.gov. And so for this, either email that you reach out to, you'll receive a response from. We are in close contact with our colleagues at OASAS. And then down here at the bottom is our core services website. And so this website down here is where all of our guidance is housed. And so this is actually the front cover of our operations manual, which is more so for the designated providers to operationalize core, but there's a lot of detailed information in there. We also have billing guidance, in terms of rate codes, information like that, that is a little more detailed than what we were providing here, but there's a lot of resources on that website. And with that, we are open to taking any questions that might be out there.
We've got some more questions in the Q&A. So, feel free to keep them coming and I'll keep up as best as I can. Let me see where to start. How can a housing provider get an update about the engagement with their patients? Is like HIPAA consent needed to obtain information from core providers, but how can we really embed that into a wraparound care team?
Yeah, so you would discuss with the individual in your housing or the individual that you're working with to let them know about core services and if this is something that they were interested in. And so to have that open communication with the core provider and the housing provider A consent would be signed, of course, to be able to have that open discussion. And I'm sure it would be housing filling out a consent, but then probably also core having housing sign a consent. And so HIPAA and the consent is a critical piece. Without the consents, there wouldn't be discussion back and forth, but we really, really value that collaboration so that housing and core can have the full picture together, and it will also be counting as a collateral for core.
Great. Our dual enrolled folks, so people who are engaged in Medicare and Medicaid, recipients of both, are they eligible for HARP and then core services?
And so this is newer. As of January 1st, we do have a MAP carve-in for core services. And there's more training coming, so I don't want to speak to that. I'm definitely not the expert in that area, but there will be training coming out. We're in the process of preparing to record a very similar recorded webinar like this with our colleagues in Division of Managed Care who are the experts in that area. So this is new for us as well, and it's basically about a month and a half old. But yes, that is something that is coming forward with more information.
I just want to add, though, for the most part, with a few caveats, individuals who are dually enrolled would not be able to receive core. So Amanda pointed to the Medicaid Advantage Plus plans, which we're very excited about. It's a form of Medicaid managed long-term care. Those individuals will be able to access core if they have the H9 code. So if they've been identified as someone with high behavioral health needs. Compared to the HARP population, I want to say that number of individuals right now is only about 3,000 statewide, give or take. So it's a very small population and certainly nowhere close to a majority of dual enrollees. The other little exception is that currently we are still under a federal public health emergency, which is slated to end May 11th. So from now until May 11th, if someone became Medicare eligible during the last 3 years during the emergency period, and they were already in a HARP, they didn't lose their HARP status. So we do have a number of people who, for the next few months, are technically dual eligible. They have Medicare and they have HARP, and they can receive core services. But that's related to the public health emergency. So by and large, the answer is and will continue to be for some time that duals don't have broad access to core services.
Thank you. On that note, Beck, can you touch a little on how H9 codes on Medicaid?
So H9, in addition to, there are other H codes, there's 1, 2, 3, 4, 5, and 6. The H codes are a form of Medicaid restriction exception code, so that's an RE code. And it is applied automatically by the Department of Health when they run the HARP algorithm. So they are looking at a ton of data, mostly claims data. They're looking for ER use, hospitalizations, they're looking at diagnosis codes, they're looking at housing status. And when someone is picked up by that algorithm as being HARP eligible, the Department of Health applies an H code in eMedNy. Now, if that person is already enrolled in Medicaid managed care, they just had what we call mainstream, like standard normal Medicaid managed care, and they get picked up by the algorithm, if their MCO offers a HARP line, and most do, that would be automatic. So if they are with Emblem, if they're with Excelis, if they're with Health Plus or Health First, and they get picked up by that algorithm, they'll automatically be enrolled into that HARP. There are a couple of Medicaid managed care plans out there that don't have the HARP product line. I can't even think of one off the top of my head. Out in Western New York, I believe it's the BCDS of Western New York does not have a HARP. In that case, the person would need to change managed care plans, and that's something that the person would need to decide to do. So nothing will happen automatically for them. They would be notified that they're eligible for a new type of managed care, and they would need to decide if they were going to do that or not.
Thanks, Katie. So if an organization is a care management agency, are they able to be a core provider and then refer internally, or do you have to refer outside of your agency?
I missed the first half. So did you say
if an organization is a care management agency, can they also, and they're able to be a core provider, can they refer internally, or do they have to do external referrals?
they can refer internally, and just making very clear that the care manager is not the one providing the core service. There's a conflict of interest there, per health home standards and guidelines. But yes, if your agency, if you are a care manager and you have your agency is also designated as a core provider, absolutely reach out to those who are in your agency to see what the referral process is like. We've really been trying to spread the word with care management agencies about core services. And so I think it's great even just to reach out and just have a discussion with them, to kind of get familiar with what their referral process would be.
Great, thanks, Amanda. Is this service limited to specific supportive housing interventions, i.e. are RTHP or MRT recipients eligible for services if they meet criteria?
And so I'm trying to think back to our billing guidance. We have a chart that kind of has like what's considered duplication of service and what is not. And I don't believe we have specifics on those housing related services. So I think that's something, if you wanted to send us an email, we could look into and better respond to that.
Okay. I know a little bit earlier, it was noted that like not all supportive housing is licensed housing. So I'm wondering if the question was a bit related to that.
There shouldn't really, when it comes down to core, it's all about what managed care plan is the person enrolled in, and do they have an LPHA recommendation. And the last piece that we look at is if they have duplicative services, then they should be offered a choice. So it's not an automatic no, but for example, if someone is going to an outpatient clinic and then they say, I want to get CPST, well, you can't get therapy through both. So you have to choose, but the person should be offered that opportunity to make an informed choice. With housing, we shouldn't have any duplicative services. These are separate, and we have guidance out there that says that. So as long as that person meets the other eligibility criteria, I would say that there shouldn't be anything about their housing status that would get in the way.
Okay. And since the services are a la carte, I would imagine that somebody can engage in, you can structure the services so that there's not like duplication, right? Does that make sense?
Absolutely.
Yeah. Absolutely.
Yeah, that's definitely the benefit to core services that we really like to highlight.
Yeah, that gives a lot of flexibility. So if somebody is enrolled in a health home, would core services be considered duplicative, or would that be based on what they're getting access to? Okay, great.
No, because the health home is the care coordination piece, and core is not meant to replace care coordination. So you could absolutely have a care coordinator who could make that referral to core services, because the roles would be different. The care coordinator would still be responsible for coordinating the different care, and then the core staff would come in and really provide the skill building support treatment that would be needed.
Thanks. We have a question for Nicole. From a fiscal lens, do you think that the core Medicaid service rates fully fund the services, or does the agency do you find that you're needing to supplement funding for these services?
That is a loaded question. I think that in the transition to core has been very beneficial to not have all of the administrative burdens that HCBS had. It has certainly increased our financial viability in core services. We're still getting there and increasing volume and dealing with staffing issues, but it's looking very positive. So my administrative hat And I think at Fountain House, what we really look at is not, of course, we want um, uh, everything to be financially viable and break even, but we also look at the value of the services. And so I think Fountain House at this point is been committed to these services because of its value.
We have a number of questions about specific services, so I'm kind of gonna combine them. And if we can just dictate whether or not these are services that would fall under the purview of one of the components of CORE. So looking for some clarification around, what's the ability of these services to provide self-care and things like that for somebody who's in need of mental health support. Is that something that would fall under?
When you say self-care, if the person who asked that question could be a little more specific.
We have another question here about like daily living skills and things like that. And I think you touched on it a little bit earlier in the presentation. That's not like ADL supports, correct?
Right. So if we're talking about self-care, like your emotional self-care that we should all be engaging in, then yes, we can build self-care skills. Personal care, we don't do personal care on behalf of someone. If someone is interested in learning more about how to improve their grooming or hygiene, we could do that. But it's really about promoting independence. So we're not going to do anything on anyone's behalf. As I mentioned earlier, if what they need is personal care, they need someone to help them stand up and pivot and use the toilet and shower, that is a medical service, a health service that's available under other program models, not CORE. But if you're learning about the importance of personal care to maintaining your health, we can do that. So it's more educational and instructional.
Do you assist clients who are in housing court?
I think
We
it would
could, if they're eligible.
Yeah, and I think the ISP would need to specifically outline specific steps and goals in working with them with housing court. There's a lot of anxiety and stress related to that. So certainly I can see how that could be built in. But I think it would be also specific in like how the ISP was written.
Okay. How long would you say a typical success story takes to achieve? And I would imagine that is very fluid based on the person and what they're going through. So maybe could you talk a little bit about the journey from kind of like referral to meaningful engagement, maybe?
I will say a benefit to CORE and the transition that we had for this from BHCBS to the rehab option is the interest in CORE to the actual intake and evaluation is significantly shorter. We really wanted these services to be available when the person has the confidence and vulnerability to say, I need help and I want this. And so that was something that we really pride ourselves on in having a quick intake and evaluation for these services. It really varies on, what a success story would look like. What I will say is these services started on February 1st, 2022. And so we are just over the 1 year mark. And we definitely have individuals who have since worked on what was needed and received the support they needed and have discharged. And we have individuals who have come in for shorter periods of time, kind of related to what Nicole had shared in terms of, navigating a really challenging healthcare season where you have a lot of appointments and receiving that support. And so that's a difficult question to answer, but we're also really limited because the program is only a year. So that taking that into account too, we really don't have really like concrete responses to what that would look like, but it does vary. And I think a lot of the success stories that Nicole had shared with us. Nicole, I don't know if you want to share.
Yeah, I mean, I think that just that we've only had CORE services for a year. I would suspect, and I saw this in HCBS as well, that folks might be nearing towards some of those the obtaining some of those goals that are in their ISP. But things change in people's lives, and so sometimes as you reevaluate and you go, we call them service plan reviews with the individual, there may be things that are added on to their ISP because their life situations changes. So I think it's again, the flexibility. There's no concrete timeline. And it's really based on people's needs. So.
Thanks, Nicole and Amanda. How does CORE manage attrition, given that, oftentimes clients' motivation and engagement can really vacillate pretty rapidly?
Yeah, so I think with CORE, it really is person-centered and based on their needs. And so we don't have a minimum time frame that they could be engaged in CORE. We have units of recommended unit ranges for the amount of minutes spent with an individual each week. But I think in terms of engagement, I think it varies. I think some individuals might begin and realize that this isn't for me, or if their plans might change, or they might quickly attain that goal. And so we don't have like a minimum requirement related to that. And so to speak to attrition, Nicole, I hate to put you on the spot, but I might see what your thoughts are on that.
Just a couple of thoughts I have. I mean, we really try to hire the right people that are engaging and fun to be around, and to, and that are empathetic and supportive. And so and then helping people to match people with the right staff. That also is something that we take in consideration. And we certainly have had a few people who have, not no-showed and not called back, but we don't give up too easily, right? So we'll make some phone calls and even knock on someone's door after they've already been engaged in services. So really, and using a lot of motivational interviewing skills and trying to relate to people, do things that will build that trust is really important in the beginning, to get people really engaged in service. And so we've seen it. Sure. I think it's a really good question, because I think we've seen it across the board in mental health. So those are our strategies.
Mm-hmm.
And in terms of,
go ahead.
Sorry, Lauren, just to add to what Nicole shared, even for our intake and evaluation process, in terms of like completing that ISP, individual service plan with someone, it's 30 days or 5 sessions, whichever is later. And so we really, understand that it takes a couple different sessions to really gain all the information that you need. And so that flexibility is built in for those individuals who reach out and then are unsure and, and need different methods of engagement to kind of get them officially enrolled into CORE and on board.
Is there a specific time frame or guidance around, like, if you haven't, been able to contact somebody in 60 days, would you close them out, or what would that look like?
So at Fountain House, we have a 90-day or 3 months with no engagement. But if there's particular situations that people are going through, maybe there's a hospitalization, or maybe there's something, if we're able to justify and we'll keep someone in the hopes that we'll be able to re-engage them after that particular circumstance.
Okay, great, thank you. We have a couple more questions here. So for residents who have hoarding tendencies, they're very often challenging. And, is this a support that could help the resident regularly on managing their housing and maintaining like a safe living space? And then just noting that this is not a quick fix, but rather a long journey, especially with hoarding.
Absolutely. And I think that can be a support around navigating how to even begin to go through what is in their home, maintaining that safety piece. really taking it step by step. I think with hoarding situations, they're so unique. And they are challenging, and it is a long haul situation. And so with that, I think having core as an additional support to help the housing provider kind of navigate that, whether it be the small steps that an individual is taking to not hoard certain items, or even just kind of navigate maybe certain times of year are more difficult for them. So I do think, but I do want to also clarify what core would not be is coming in to like physically clean or remove any of those items. And so it really would be specific to an individual who is aware that they are hoarding and has a plan in place to want to learn the skills needed to prevent further hoarding, but then also what skills can be taken and used and implemented to resolve the current hoarding situation within the home. And so I think it would depend on how the ISP is written, but definitely wouldn't be like a service to come in and clean, but could work in conjunction with housing staff to address the situation and provide additional support. I would think especially like even in peer support could really be helpful in this instance.
Do core practitioners rely exclusively on the referring agent for client contacts if and when the client does become estranged or loses communication? This tends to expand for the supportive housing case managers and can feel like it maybe defeats the purpose of referrals if they're managing that relationship. So can you speak to that a little bit about what that looks like once that referral is made, and how you work, I guess, with the referring providers?
Yeah, and so we really encourage to foster relationships between the core provider and the housing provider. And so it's not just making a referral, wiping your hands clean. It really is like a collaborative approach. And I think the consents and the collaterals really help foster that. And I think that there is the individual staff member, there is supervision. So there's a supervisor and director that could be reached out to. I think oftentimes it might actually be core providers trying to reach out to housing providers, and sometimes that switches, and there's a lot of turnover in the workforce as well. And so I think it's important to make sure that you have not only the contact for the specific housing staff and the specific core staff providing the services, but also have contact information for the supervisor above them. And also, you could always refer to the designation list as well. But yeah, ideally you would not be chasing around, there would be that collaborative approach to make sure that the goals that are being worked on complement what's being worked on in housing as well.
Yeah. And I would imagine that, if folks are able to set up some sort of like wraparound care team that encompasses everybody who's involved in their client and is establishing like regular communication, that would kind of inevitably lead to more understanding of how engaged they are or not in different services, and keep everybody kind of like in the loop without overburdening one party.
Yeah, and that is why, the collateral was built into the billable piece for core as well, because it kind of, you are spending time making connections and just kind of seeing how the individual is doing in other areas. And ideally that would work, but I also know that, across the entire behavioral health system, we're always talking about communication, collaboration, picking up the phone, sending emails, and making those connections for each individual's essentially support team, and making sure you're getting the full picture. I think that is really important, but also we're always talking about communication, and it really is critical, because you're really only seeing a piece of the entire pie, so to say, for that individual.
Alrighty. And one more question. I think it's a really interesting question. Do you have any failure stories where the client, peers, and caseworkers kind of did everything that was humanly possible and still were not able to successfully engage the person and help them accomplish what they'd set out to do? And has that illuminated any kind of like gaps or opportunities for doing things differently?
And so I will say, I can't think of any specifics, but I also acknowledge that we're the state. So they may not be quick to share what they would consider a non-successful story. We do ask providers for the feedback if things are not working. We've really been working collaboratively with our core providers to kind of get a better understanding of what is working in practice, what's not working in practice. But in terms of like a specific story, Nicole, I don't want to put you on the spot, but
Oh
you
gosh,
have the best.
I'm just trying to think. I think there's been a couple of, we've had certainly some failures in engaging people, that they, their provider, somebody who, made the referral, but maybe the person wasn't really so gung ho about it and kind of went through the process, and the services didn't stick. That has happened a few times. And so we're always looking within and saying, how could we do things differently? And what, so that's sort of a self-evaluation moment.
That actually sparked a thought in my head. I will say, I wouldn't necessarily call it a failure, but a failure in communication. In the beginning, providers were receiving referrals because they thought that CORE was like a personal care service. And so people would be referred, and then core staff would go in to do the intake and evaluation. And they were like, well, my dishes are over here and my laundry is here. And there's that miscommunication for what core is. And you'll notice it throughout this presentation, we've tried to highlight that several times just to kind of clarify that is not the role of core staff. And so not necessarily a failure, more like a failure in the understanding of the service, but Nicole's.
I can give you another example. We have a homeless outreach team, and there was somebody who was engaged in cores, working on the relationship, but this person is unhoused. And so of course you have the option of being able to come in site, but we had a hard time locating this individual to be able to provide the services. So that was a barrier and a challenge for us. We're still working on that, but that's something that I guess I would say hasn't been a total success story yet. I'll say yet.
Alrighty. So is OMH also like advertising and educating the community and consumers about core services directly?
So we have been doing a lot of training within the behavioral health network. And so we've done a lot of community trainings. We've done presentations at multiple conferences. But what I will say is the actual core providers have been marketing themselves. Flyers have been created. We've seen mass mailings. I've seen pens made, mailed brochures, and in terms of like reaching out to specific individuals, the core providers have really been marketing themselves to receive those referrals. And then on the state's end, we've been trying to really educate the field itself, very similar to trainings like this. The idea for this training actually came from another presentation that we presented at, and staff from the consortium came over and asked if we thought that we could provide this for support housing providers. And so, a lot of networking, a lot of conferences to just educate the field and get out there with what core services is and how this can be a benefit. And then the more person specific, we also have MCOs who are also aware of these services. And so they should be looking at their members and seeing who might benefit from core services. So there's a lot going on. I'll acknowledge that I don't think the message is getting out as fast as we would like, just based on the questions we've had to clarify over the last few months. But yeah, there is a lot of moving pieces going on out there.
I just want to highlight, and I know we're running out of time, but the very last effort, which we didn't talk about because there wasn't a lot of time, is the Core Peer Navigator Project funded through NIAPers. So NIAPers is a statewide organization. They have a grant from us to hire peer navigators statewide who are supporting HEART members with learning about these services and accessing them. And so NIAPers is actually able to provide a peer navigator who will work with the individual on engagement while they're perhaps sitting on a wait list, which unfortunately exists in some areas. They'll help them find the right provider. They'll help them learn what CORE is. So the phone number and link to information about that are in the chat box. And certainly if you want more information about CORE Peer Navigators, you can reach out to us at core-services@omh.ny.gov.
Yeah, thank you, Katie. And just wanted to note too that Tess put some information in the chat here about upcoming events and sessions. And there's also a survey, if you could please fill that out. And actually, Tess, I'll throw it back to you to close us out. Thank you.
Hi, everyone. Thank you so much for that. This was such an amazing training, and you all offered so much important information and expertise. And Lauren, such a great job moderating. Thank you so much for doing that. I just put a brief feedback form in the chat. Let us know what other trainings would be helpful for you. We'll do our best to offer them. And I added a few upcoming events, one of them from OMH, in the chat as well. So definitely register for those. We'll be following up with the recording and the slides shortly. And yeah, thank you again to all of our presenters.
Thank you
Have
so
a great day, everyone.
Thanks, everyone.